All right. So, 52-year-old guy basically came in. He's got real no past medical history, and he comes in with, 2 months of fatigue. He's got a white count of 45,000, platelets 29, hemoglobin 5. Retic count was, not negative. ER starts him on some cefepime, and they consult hemonc, who starts the guy on hydroxyurea and admits him to their service. All right. So this is really basically his hospital course over the 2 weeks that he's in the hospital before critical care gets involved, right? So bone marrow biopsy comes back positive for ALL. They put him on steroids. They start him on vincristine. They stop the hydroxyurea. They start him on, a hyper, immunosuppressive regimen, and they put him on acyclovir, fluconazole, and Bactrim prophylaxis. His cultures are negative from his ER stay, and a couple of days later, they stopped the cefepime. A week later, he's still not having fevers, but he's not having really bowel movements. They're concerned because he's having worse abdominal pain. They get a CAT scan of his abdomen, which is negative. The next day, they consult surgery because now he's having some abdominal pain and vomiting. Surgery season says, just continue to monitor him. And then later that night, his heart rate goes up, his BP goes low. They give him some fluids. He has a bowel movement. They get a CAT scan, which shows basically long segment colitis, concerning for tephlitis. They start him on Zosyn, and pretty much immediately at that time, his blood cultures come back for gram-negative rods. At this time, his WBC count because of the induction chemo is below 1. The cultures come back, 2 days later, basically showing that even though he's gotten improved with the Zosyn, the E. coli is resistant, so they switch him back to cefepime. He still has some ongoing fevers after getting changed back to the cefepime, which should be sensitive. They repeat a CAT scan, which basically shows no change. They repeat blood cultures on the 28th with the ongoing fevers, and those cultures are negative. So basically that night, he has one very small bloody bowel movement. It's not diffusely bleeding. His platelet count is 9. They give him a unit of platelets. 15 minutes after the platelets start, his blood pressure drops. It's got a temperature. They stop the infusion. They give him an LR bolus. Within a couple of minutes, now his blood pressure is 60/30. He's hypoxic. They put a non-rebreather, and they call a rapid response. So my question is, what are your thoughts? What do you think is going on? What are you going to do?
Well, like in a real case, we ran through it so fast. I'm going to worry about the ABCs first.
Okay, so he's satisfied on a non-rebreather. He's talking to you. He's just hypotensive and febrile.
So obviously resuscitate first. This is where treat before you diagnose. Try and get the blood pressure better. If I have to use vasopressors, I'm using vasopressors. Assess volume status. Give him fluid if I need to. So
he basically start him on Levophed, give him another unit, or give him another liter of fluid, and at this point we get him to the ICU, and we put an A line in him because he's already got.
Do we have? I know his, based on his history, it likely is due to malignancy, but do we have evidence of blood loss?
Just aside from the one very teeny tiny, almost bloody smear of a bowel movement that he had, that kind of triggered them to give him the platelets. He hasn't had any signs of diffuse hemorrhage, no.
And based on his exam, his perfusion exam, extremities, capillary flow, mentation, are we concerned about blood loss?
I mean, his mentation is off. His mentation's fine. His mentation was fine the whole time. His cap refill was delayed. He's got no complaints of leg pain. Put an ultrasound probe on his heart. The LV is hyperdynamic, and the RV is basically normal appearing.
Yes, I mean, you mentioned, right, the LV being hyperdynamic. That actually supports that, he's probably not fluid responsive because it's already pretty hyperdynamic, and his cardiac output is good. So then I think I'm addressing it more from a distributed pathway. I have on pressors. I'll see if I need antibiotics, and I'll probably consider stress dose steroids if it's going high enough.
So
And is he acidotic?
I don't think I ever got an ABG, but he was already on 40 of dexamethasone as part of his chemo regimen. So what's your differential? The guy drops his blood pressure during a blood transfusion, but he's also still on antibiotics from bacteremia.
Yeah, I mean, it could be taco or it could be trolley.
So this is what I came up with. In my mind, this is what I was thinking, right? Like why this guy was in shock is he could either A, be having acute hemolytic transfusion reaction. Charlie's on the differential too because he's febrile and hypoxic. He could be anaphylactic. Him being febrile will go against the anaphylaxis. It could just be fluid septic shock. There could just be that he's going to have bigger bloody bowel movements, or this is a guy with almost no platelets but active chemo, but he hasn't been getting any sort of anticoagulation because his platelets were so low. So he could have just developed a DVT-PE. The lack of RV dilation would kind of go against that. So
yeah, I mean, you mentioned the respiratory wise, he's overall stable. I mean, he's hypotensive. Yes, it could still be anaphylaxis, but really, I'm amongst these causes. I'm based on like what you're telling me with the LV being hyperdynamic and the cardiac output being good. I'm leaning towards, and the RV, the right-sided echo that you're getting is also good if it's reliable. Once again, I think septic versus hemolytic transfusion reaction.
And then what would be your vasopressor of choice? Would you stick with regular norepi?
Yeah, I mean, once again, I do it like I'm going with the regular norepi, but I guess where are you now on the norepi?
I mean, I think we pretty rapidly went to like 15, 20, or 25.
Yeah, until I ruled out sepsis of adding vaso. And you said the right-sided function is good, right?
Yeah.
Yeah, then I'm comfortable adding vaso. I'll see how you respond to that.
All right. So this is what I did. So I started him on epi because I wasn't 100% convinced maybe he didn't have an anaphylactic reaction to the blood transfusion. So if it was an acute hemolytic reaction, the answer is to give fluids and stop the transfusion and give fluids, and then maybe give them diuresis. Nobody had ever sent a C. diff level on this guy. I basically immediately gave him a dose of meropenem in case he was for some reason outgrowing MDR, and that's why he was still spiking fevers on the cefepime that the E. coli should have been sensitive to. Basically, acute care surgery was involved because they had already been following, and they kind of responded to the rapid response because he was on their watch list. And in speaking with the trauma doc, she was like, "Look, if you think he's bleeding, and he could be because of the colitis, like you gotta, resuscitate him." So he ended up getting a trauma pack. I gave him 3 units of PRBCs and 3 of FFP and 2 of platelets and 10 of cryo. I think because his fibrinogen came back low on some blood work, which could technically still be the fibrinogen could have came back low because he was having a hemolytic transfusion reaction versus ongoing bleeding because it can come back low because that kind of looks like a DIC picture. He still had like maybe 1 or 2 like liquid bloody bowel movements, not diffusely bloody, but like just kind of like more maroonish. And so I figured, what do I have to lose at this point? And so I gave him a gram of PXA. The rapid response was around 2 o'clock, and around 5 o'clock, I weaned him off of. I think he was at one point on like a little bit of epi, some levofed, and vasopressin. And at 5 o'clock, after all the transfusions went in, he basically came off all the drips. So at this point, I was thinking it was maybe hemorrhagic because the only thing I did was volume resuscitate him. So now what? And he's now what would you do? Are you thinking you're going to CAT scan? You think you're gonna like? What are you thinking?
Yeah, but until I get
Apart
his
from-
hemodynamics a little more stabilized, I'm not comfortable going to a CAT scan.
Apart from that small bowel movement, we still don't have a definitive source of bleed, correct?
No definitive source of bleed.
I mean, and where are our pressures at this point?
Right now they're off. After he got all the blood products, his pressure requirement is
Oh yeah,
is off.
then I think I would consider a CAT scan. The pressure is more stable now.
Yeah, agreed. And if I'm really that worried about the patient, I'd probably go to CAT scan with him.
So, at this point, I had him on a non-rebreather, but I transitioned him over to high flow. And basically, after all the blood transfusion, he's going to escalating doses of.
Wait, sorry, you mentioned he was.
oxygen.
Yeah, I mean, I guess so. Why were you concerned about an anaphylactic reaction?
So, basically, within 15 minutes of getting the blood transfusion, he drops his blood pressure and becomes febrile. So,
Are you concerned about airway? Because then obviously addressing that first.
yeah. So his abdominal pain is worse. So I know he's got to go to CAT scan. I gave him a big slug of Lasix, and I thought about either BiPAPing him, but I was hoping he would diurese on his own because his kidney function was normal, but then his blood pressure kind of started to go down again. So I started him back on some epi, and then I put him back on vaso after that, and then before after the sign out with the fellows, we talked to his wife and we intubated him.
How was the airway? Any idea?
It was an easy tube.
No, like a word swallowing or anything.
No. So now he's intubated. He's on some drips. So now what? What do you think? Your airway's taken care of. You're back on some drips. You going to CAT scan, or because he got better with blood resuscitation, do you think you're going to give him more now that the airway's secured? Like, what do you think?
Are we concerned that this could be a heme emergency?
What do you mean a heme emergency?
Like a blast price or something. Because you mentioned the Viacom was crazy high first, right?
Yeah, I think the one the day before was like 0.2. The induction chemo worked. It worked too well, actually.
Oh, TLS.
Well, it could be. That's a good thought.
I mean, at this point, I bought myself some time now. If he's still stable, I'm repeating all my workup.
All right. I took him to CAT scan because I didn't know if he perfed or not, and I thought maybe that's why. And basically, what happened is now the CAT scan is showing diffuse colitis. The C. diff that I was able to get earlier came back positive. So with this, I talked to surgery. Surgery's like it's fulminant C. diff. It's not tephlitis, or it's a mixture of both. And he was having some ischemic colitis. So we think we're either going to take him to surgery now, or he's just going to die here on the floor. So they took him for a total colectomy. They kind of temp closed him, and he got additional blood in the OR. He comes out. ID was now here, so ID gives him a dose of Flagyl as well as Cefidoricol. Post-op day 1, he's off of pretty much a lot of the pressors that he was on. Surgery took him back on the second day just to make sure they didn't miss anything and they didn't find anything. And he basically, he's in the hospital for like another 3 weeks. He gets extubated after the post-op day to look back, and like within like 2 or 3 weeks, he basically leaves the hospital. So what happened is that on the 26th, the 25th, he grew E. coli. That's when they put him on Zosyn, and then they switched. He had a repeat culture, which were negative. They switched him to cefepime. During the rapid response, I sent off blood cultures. That ended up coming back growing MDR Klebsiella. And then after he left the ICU, he had fevers on the floor, and he ended up growing stenotrophomonas. And so this guy was on a ton of different antibiotics throughout his hospital course. And I think he got discharged on like the 17th or something like that. So I thought this was a good case because when the shit hit the fan on this guy, you had no idea if this was a transfusion reaction, just worsening sepsis, if it's hemorrhagic, which I think you have to say it kind of was like some form, because even with all these blood products, like we didn't resuscitate him to like a hemoglobin of like 15. And just, there's always the outlier of, is this, is there like, a PE or something else, and kind of making the decision, based on like a bedside ultrasound or your bedside, clinical judgment that, RV's not blown out. It's probably not that. But what I thought was, and I didn't do this at the time, is I didn't send off the hemolytic transfusion reaction labs. Like I didn't send off the Coombs test. I didn't send off like the LDH and things like that, like that I should have. And then it was important because if this was an issue, like this guy would have, I give this guy more blood. So if there was an issue and they're going to give this guy blood from like the thing that they had just typed and crossed him for, then that would have been a big issue. But when I was doing the case, I didn't think about that. So basically, I'm just going to take a second, if it's all right, to just go through transfusion reactions, because it's definitely going to pop up on your critical care board exam. We give a lot of blood products, and I don't think that I've ever put in my mind exactly how to work these things up or how to divide them out. So one is, most of the time, they're going to be just febrile non-hemolytic reactions, right? Like that's the most common. Trolley is unlikely. Taco's unlikely. Some of them are going to be mild allergic reactions, which we don't care about. And then other ones are going to be, delayed reactions, like acute anaphylaxis or acute hemolytic transfusion reactions are very uncommon. But I think we're going to have to go over them because the vast majority is the allergic reactions and the febrile non-hemolytic, like we don't really care about, right? Like we don't do anything for those other than stop the transfusion and give them Tylenol or give them a little bit of Benadryl. So if they have fever, the things that you need to think about are basically one, and the big bad one is this acute hemolytic problem. There's also, and there's also the possibility that that this guy didn't get septic until he got the blood transfusion, right? Like maybe we gave him this MDR Klebsiella. It's probably unlikely because he ended up growing like stenotrophomonas later, but it's still on the differential, and I didn't even think to look at the platelets. It's unlikely because he was getting platelets. It's typically only when you get PRBCs, but I thought it was worth going over. So basically, this acute hemolytic transfusion reaction, it generally doesn't happen within the first. It can happen within the first 15 minutes, but it's generally going to happen at like the 1 hour mark, right? It can't always happen earlier than that, but most commonly it's going to happen at the 1 hour to 2 hour mark. It's always because of clerical error. Either the lab sent you the wrong blood, or the nurse didn't confirm the right blood before giving it to the patient. It always presents with fever, shock, and DIC, basically. So you're going to show hemoglobinemia. The DAP is the direct Coombs test is almost always going to be positive, unless by the time you draw it, if you're delayed in drawing the Coombs test, all the donor blood has been destroyed, in which case then the DAP will be negative. You're always going to see hemolysis labs with the bilirubin, the LDH, the haptoglobin, the fibrinogen, and then a smear should basically always show something. So it's important that you get at least the hemolysis labs and the Coombs test and a smear, because it's going to help you kind of rule that out pretty quickly. You're basically just going to stop it, flush the line, and try to dilute out with a lot of just saline, because the degree of the reaction is basically based on the amount of blood exposed. Some things they'll say, if you're in the hypercoagulable phase of DIC, you can always use heparin, but that's in the textbooks. I don't know if I would ever do that. And then also, if a lot of blood got transfused in, sometimes you actually have to give an early, like full exchange transfusion to just get all the bad blood out, basically. Second thing is going to be like the transfusion related sepsis. This is almost always bacterial. It's almost never a virus. It happens with older blood. That's going to pop up on your board question. The older the blood is, the more likely it is to give you transfusion related sepsis. Platelets tend to have gram-positive organisms or skin contaminants. RBCs, based on how they're stored, tend to give you something that's been growing in the blood. These are almost always gram-negatives, right? Yersinia is historically the most common, but it can be any of the gram-negatives. So platelets think gram-positives, PRBCs think gram-negatives. That's why I don't think it was a transfusion-related sepsis, because his reaction happened when he was getting platelets. So rapid onset of fever, abdominal cramps, it's going to basically happen because you're basically inducing septicemia as you're transfusing the blood. So it's going to happen the second you hook up the transfusion, right? Acute hemolytic basically don't have as dramatic of a presentation. It really will look like just diffuse anaphylaxis, except with anaphylactic reactions don't have a fever. You may see this in discolored blood products. Gram stains are not always definitively positive, and the DAT would be negative. So then, Uday, you had brought up trolley. So trolley is basically the number one cause of fatality. Basically, anybody who's got a new acute lung injury within 6 hours of transfusion is considered for trolley, especially if their P to F is under 300. The differential is always taco versus trolley. Trolley comes with a fever, taco doesn't. Taco is basically what I probably did to this guy was I gave him taco, and that's why he got so hypoxic, because I hammered him with, 8 units of blood products within a 2-hour period. And I increased him from just like regular, like nasal cannula all the way up to high flow. Trolley happens because the neutrophils basically react with within the pulmonary endothelial cells that create leak. It's a neutrophil problem. There's a couple of different ways to get there, but the question on your board is going to be what causes trolley, and the answer is going to be neutrophils. And then for your febrile but your non-hemolytic transfusion reactions, so there's a couple of different ways this can happen. It can happen either A, the substances develop the cytokines before the transfusion, which is more common with platelets, or B, the recipient's anti-HLAs interact with the donor white blood cells, and this always happens after the transfusion is given, which happens mainly with blood, like packed red blood cells. So for the non-hemolytic, if you're giving platelets, it pretty much happens immediately. If you're giving WBCs, it's going to happen or if you're giving RBCs, it's going to happen in a delayed fashion. Basically, the lab findings are negative. The treatment is just antipyretics, and the way you prevent it is that you leukoreduce basically all the blood transfusions, and labs do this routinely nowadays. So this is why this basically never happens anymore. So what if they don't have a fever? Because it sounds like the difference in what your diagnosis is fever, no fever. So if they're not having a fever, the things you worry about are allergic, anaphylaxis, and basically volume overload. I don't care about allergic reactions, right? I don't care. You're not going to do anything for them. You stop the transfusion, you give them some Benadryl, and you tell them that their urticaria will go away. But you do care about the anaphylaxis, because this happens basically the second you hook up the blood transfusion, you're going to induce anaphylaxis. They all have skin findings, right? None of them should have a fever. And classically, this happens, and this is going to come up. This is going to be the board question, right? How do you get an anaphylactic? They're going to give you a scenario where they're getting a transfusion reaction. They don't have a fever. They develop acute shock. And the question isn't going to be anaphylaxis or not. The question is going to be that their IgA deficient recipient has formed antibodies, and they form a type 1 hypersensitivity reaction. And the reason why the board loves this is because they get to test a clinical scenario with a physiology question, right? And that's why transfusion reactions are going to pop up a couple of times on your boards, because it lets them test like step one questions in a clinical scenario. Basically, you can prevent it by if you know they're IgA deficient, you'll give them washed cellular products. Most times you don't do that, and it's fairly common that even if you have a severe history of allergic reactions, that you end up getting untreated transfusions in the future. And then obviously the treatment for anaphylaxis is always epi. So with my guy, because he developed all these symptoms acutely, my thought went to it could be transfusion, but I've already stopped it. I've already flushed him. It could be anaphylaxis, which is why I put him on epi. And then, of course, it can always be sepsis induced, which is why I basically immediately gave him a dose of meropenem. And then the rest of it, if it's taco or trolley, it's really just supportive care, diuresis and intubation if necessary, which we eventually got there. Taco, again, basically, you could send off a BMP. I don't know the utility of that. And then it's all just supportive care. And then for fulminant C. diff, it's funny that this one doesn't necessarily normally fit the classic definitions because he was on induction chemo. But he basically fit it because he was in shock. And the CAT scan came back showing basically diffuse colitis with a positive C. diff. So I bring this up because, a lot of times you hear surgery give a lot of pushback for taking these patients. But if you actually look at the surgical literature on this, patients do have a better outcome with early subtotal to total colectomy with an endostomy than they do if you wait. Because if you wait, they just get sicker. And I think we all know this. What they do is basically they leave it's a Hartmann's procedure, and they bring up and they leave a rectal stump. Sometimes they'll infuse like rectal vancomycin into the stump. What they should do is they should sometimes leave a Penrose drain actually put in like transanally to help drain, or have a very low threshold if the patient keeps developing fever or isn't out of shock, to go back and look at the stump, because the stump is going to be where the problem is. It's going to be on the rectal end, the rectal stump, because you're going to do a subtotal colectomy and bring the bowel up to the wall. So you're going to form an ostomy, but the rectum is just going to be left in a stump. But the stump is where you're not getting good blood flow. So the PO and IV antibiotics aren't getting there. So that's where you get leakage from, because the C. diff is still actively in that part of the bowel. That's why some of them will infuse vanc rectally so that it's getting like some sort of there, or they put a drain in to help drain away any of the infection. And then tephlitis. This is something, we see it in adults. It's more common in kids because I think basically it happens with people who have AML and ALL. It's always within 2 weeks of chemo. They get profound neutropenia. They get invasion of your gut mucosa from breakdown from the microorganisms. And if you look at the drugs that most commonly cause it, cyclophosphamine, vincristine, all the medications that this guy was getting with his hyper VCAD is the ones that are going to cause this problem, right? And it's an incredibly high mortality rate, right? Like 21 to 50% of these patients, they just die. And so it's always gram negatives, right? It's always from translocation. So Clostridium, E. coli, Klebsiella, right? Like these are all the things that our guy grew basically is on this list. Clinically, there's going to be fever, abdominal pain, nausea with neutropenia. Distension's common. If they have already developed ascites, it could be because they're just developing abdominal compartment syndrome, which would be another reason to push surgery to go to surgery. But if you look at it, melena and hematochezia are rare occurrences. So our guy had bloody bowel movements, which is uncommon with the tephlitis. CT is basically going to show a thickened cecal wall, and as it goes up, if your colonic wall thickness is thicker than 1 centimeter, that's an indication for surgery. If there's perforation, if there's pneumatosis, if there's basically total colonic inflammation. All these are reasons. Most of the time, though, surgery's not going to take them unless they see pneumatosis or if there's a perf. That question will definitely pop up. It pops up on your chest. It pops up on the ATS. I know it popped up on my board exam is the diagnosis of tephlitis. When is surgery taking them to the OR? And the answer is going to be perforation. That's going to be the answer. So who needs surgery? Again, bowel perf, abscess, pneumatosis necrosis, or if they're uncontrolled bleeding. That's it. So I thought it was a good resus case because I think we always have to keep our differential broad. And, you know, we always think sepsis, hemorrhagic, but, you know, really thinking about these transfusion reactions and especially anybody getting blood products and how the timing, fever, no fever, really dictates it. And maybe in some cases choosing vasopressors that aren't necessarily always our first line, but just to cover all of our bases. I think in this case, I don't think it helped in his case, but I think it was a good thought process to go through.
That was awesome. Thanks, man.
Alrighty. Any questions? Sorry, that was quick. Thanks, Dan. Give me a call.
Oh, that's a little.
All right.
All right.
All right.